How has your approach to CLTI case, how has it changed in the past 3 years? And by that, I kind of mean, are you doing more imaging? Are you opening up more devices? And with this vessel prep, I mean, are you doing more or doing less? Mike, what about you?
I'd say when I think about over the last 3 years, I wouldn't say that my practice has changed too much because I think I've always been somebody who's willing to get more information or do something different. I think conventional angioplasty, just straight up PTA, is the same thing people have been doing to treat blood vessels since the 90s, right? So from that perspective, I've always been trying to do things, very different to historical precedents. 3 years ago, I was using a lot of intravascular ultrasound. 3 years ago, I was using a lot of specialty balloon technologies. And 3 years ago, I was using drug-coated technologies where they were available. I think the only couple of things that are brand new to me in my practice in the last 3 years would probably, be the use of the bioresorbable scaffold below the knee, and up until very recently, having access to retrievable stent technology, right? So specialty scaffolds for the BTK space. But apart from that, my practice hasn't changed too much.
In your training too, were they also pretty, involved in doing specialty devices, or was it more POBA and possible bare stat?
I think that the practice where I trained, so I trained at MedStar in Washington, D.C., and I was really lucky to have trained there. Incredibly fantastic surgeons who were very forward-thinking and progressive. So they were always people that were willing to try new technologies. I remember, using shockwave or intravascular lithotripsy, in the thigh when I was like a second-year resident, third-year resident. I remember we were a site that enrolled patients in, Promise, the DVA technology. So access to specialty technologies were there. And I think my interest in doing things that are unconventional or not just PTA and bare stent definitely came from where I trained and the people who inspired me there.
That's great. Jay, what about you? Being technology junkie, as you mentioned, I mean, compared to when you did training, let's increase it from 3 years because 3 years is not that long, but how has it changed?
Well, no, I mean, I'm old enough. I got a lot of gray hair, I guess now, but we didn't have anything back in the day, right?
Yeah.
So we were just making up as we were going along. The BTK world, and even ATK to a point, was the Wild West. And so all we had was balloon angioplasty. And, we blew up the balloon, looks kind of good, got out and moved on, right? And we now know so much more about recoil, about medial calcification, dissections, all these things. Didn't know anything about that too. So imaging is I think one of the biggest things has changed. And then using that information to kind of inform what kind of devices. And so we've had this arms race of lots of different technologies, some of which have really taken off, some of which have kind of faltered. I used to, for a while, I went through that atherectomy phase that a lot of people went through. Now we know BTK atherectomy may not always be the optimal thing to do, depending on the pathology. And, I think imaging really has informed a lot of what we're going to do, especially with some of these vessel prep technologies.
Totally, yeah. Speaking of imaging, tell me, what are you guys using for imaging? What's your typical non-invasive imaging workup for, a CLTI patient that you're seeing in the hospital? What kind of imaging do you have before? And then what other adjunctive imaging, such as IVUS or anything else, are you using, Michael?
Yeah, so I think especially in the inpatient setting, I think our emergency department, the residents who are on call, they reflexively get CT angiography. Worst test to get is a unilateral CTA for a patient with bilateral wounds, but it happens. But I think CTAs happen very, very often. And I think everybody who takes care of these patients know that your ability to image and truly see what's going on in the popliteal artery and distally in the setting of CLTI, is really limited. Additionally, I think we reflexively get a lot of ABIs, which, obviously have a lot of shortcomings in this patient population due to the calcific burden of their tibial vessels. Oftentimes we get non-compressible ABIs where the patients have TMAs and you can't get toe pressures. But that's the system within which I work. And oftentimes if a patient doesn't have a palpable pulse and they have a non-healing wound, I think the extension of your physical exam is lower extremity angiogram. And I think in the wake of best CLI, everyone was saying everyone should get a saphenous vein duplex. But oftentimes, just by looking at a patient's leg, you can assess whether or not a patient's going to have adequate saphenous vein. I think at least 50% of the time. So I'm taking these patients to the OR, our hybrid room, oftentimes with a CTA, which doesn't provide a lot of insight, and arterial non-invasives that basically cast a wide net to determine whether or not someone may heal or may not heal.
Do you find renal disease being any kind of, limiting factor for getting CTAs in your population, or you don't have too much renal insufficiency?
We have a fair amount of it, but I think the quality of imaging you can get with low contrast volume CT angiography today allows you to, I don't really think there are that many patients who have a CTA as a contraindication. Now, I personally don't need a CTA to take somebody to the cath lab, right? Palpable femoral pulses and a non-healing wound. I think that's all you need.
Jay, what about you?
Yeah, I mean, we have a CT scan in our office even, but I'll tell you that a lot of these patients, especially the CLI patients, they have a lot of chronic kidney disease, and you can give 100 cc's of contrast for a CT angiogram and still not see infrapalpiteal disease adequately because of the calcification. They have no idea whether the vessels are open or not. So fortunately, I think they've moved away from that in the hospital setting, but they do a lot of duplex. The problem with the duplex is that unlike our vascular lab, which is accredited, a lot of the studies that are done in the hospital I find are pretty subpar. And then they're read as, patent vessels, everything's monophasic, there's no description of anything. So already your index of suspicion is higher. And I can tell you, we can do an angiogram with very little contrast. I mean, with an endo catheter and a 3 cc syringe, you can give 50-50 contrast and do an entire angio and intervention and with, only about 10 to 15 cc's of dye. Or you can use CO2 as well. And especially if you use anesthesia, they don't move around, you can get very good imaging. So and then you combine that with IVUS, it tells you everything you need to know. I mean, you could do the whole thing and use IVUS imaging as your adjunct to get a better sense of what's going on. Now, I'll tell you that, we use a lot of Phillips IVUS as well, too. It's really good. Sometimes when you get to the smaller vessels, like the tibial vessels, it's harder to see intimal plaque because of the imaging resolution. So obviously there, will be hopefully some new advances on that front as well. But I think that we have a good sense about size. And I think that's really important because one big issue in the tibial intervention space is that people tend to undersize their interventions, which can obviously lead to recoil and early failures. May have been one of the problems in some of the earlier studies that have been done with different technologies. But I think IVUS is really an important thing for all of your CLI patients, CLTI patients. You want to get an understanding of pathology and also sizing of vessels.